Good morning, everyone, and welcome to the September Senior Health Connect Value Webinar. Glad you could join us at this early hour. It's top of the hour right now. Maybe give another minute just to let a few more people jump on. We have a couple of different topics today, all of great interest and pertinence to the work that we're doing. So thank you for joining. So today's agenda will include 3 speakers. Joan Kirk will be talking about patient experience performance and the We're Listening campaign. Many of you probably have not heard about this yet, so that will be new news. We'll have Valerie Choniak joining us. She is the Agilon Director of Patient Experience, and we'll be further discussing patient experience of care. And then lastly, Matt Brand, who is one of our lead clinical pharmacists at Answer Health, will be talking about the statin therapy quality measures. Before we begin the speakers, there are a couple of announcements. The first is the Save the Date. Our Answer Health Senior Health Connect 2024 Achievement Dinner will be happening on Thursday, November 7th at Thousand Oaks from 5:30 to 8:30. So please pencil that in on your calendar. And then if you can flip to the next slide, Matt. The Wellbeing Index is something that is offered kind of as a joint effort between, Corewell sponsors it, but Answer Health has this as an offering. It's basically a measure of your well-being, and it's something that you can take more than once a year if you'd like to, but the Wellbeing Index is open right now from September 9th through the 27th, which that's kind of short notice. I don't know if it's going to be extended at all, but if you scan the QR code, it will ask you a series of questions. It only takes a few minutes to do it, but it may provide you with some very interesting insight if you're interested in taking it. So I think this deck will be sent out afterwards. So if you don't catch it now, you can do it afterwards. Thank you. Next, I'd like to introduce Joan Kirk. I think all of us know her, and she's going to talk to us about patient experience and the We're Listening campaign.
Good morning, everyone. Thank you, Dr. Zlasko. And yeah, we're here to talk about patient experience of care. And this is really important to our patients on how they feel when they're coming into your office. What's their experience? In addition to the good health care they get, this is really important for them. And so we're going to talk a little bit about the 2 surveys that we're participating in currently. So the first one is the National Research Corporation. And that's something we do with NRC. And we actually worked with NRC back around 14 to 19 when we were doing a pilot with the Blues and Priority Health around patient experience. So we're familiar with the work that they do. This is a mock survey. It does not count towards our performance. There's no financial or quality performance related to this, but it does give us a lot of information on how our patients are feeling when they're having care in our practices. So the way they determine who to send a survey to is that we are able to pull practice appointment scheduling data from your EMRs, and that's sent over to NRC. And when that date comes up, that's when that survey process will begin. The survey questions actually vary very slightly from the Blue Cross survey questions that count, but they do give us some direction on what our patients are experiencing. And so once that appointment time passes, the patient will receive a call within 24 hours after the appointment. The second call, if they don't respond to that or pick up that call, a second call will go out about 24 hours later if needed. If no response to those 2 phone calls, then they will email a survey if we have an email address for them that's been pulled out of your EMR and submitted to NRC. We do get a higher number of outreaches and surveys completed with this process because they do reach out to a high volume of patients. We receive timely performance data, and we use this data to evaluate and adjust our performance and how we're doing, where we need to focus on. You also receive monthly reports on your practice and individual providers on your performance on this mock survey. It also goes to office managers now. And what's different about this survey is the last question on the survey is open-ended. It says something like, do you have anything else you could offer to how we can improve your experience? And so Most of it's positive, well into the 90s, but we do get some people who have some feedback to us that would be considered maybe negative or we have an opportunity to improve. And so those alerts are reviewed and they're sent on to the practices, to the office managers for follow-up if as appropriate. And so that's one of the benefits of the mock survey as well. If we move into the survey that counts towards our performance and meeting that 4.26 stars that we're required to meet for quality, the patient experience, our patient experience performance is included in that. And so for Blue Cross, MAPPO, and BCN Medicare, they participate in the same survey, the CGCAP survey, and use the way they determine who to send the survey to is a little bit different. They use paid office visit claims. So if you're seeing a patient in your office for a visit and you send in a claim, that will trigger a survey being sent out to the patient. And so this survey is sent by mail. And if there's no response, if the patient doesn't fill it out and send it back within 4 weeks, the patient will receive a phone call. And a lower number of outreaches and surveys are completed. So the Blues do not reach out to as many patients for the survey, a much smaller denominator. And so we do get lower numbers of return surveys, but this is the one that counts. The performance data is slightly delayed, and that's why we like getting the mock survey because we get more real-time data on how our patients are experiencing our care. The survey, I just mentioned this, the survey performance does count towards our 4.26 stars, and that's why this work is really important. Okay, next slide, Matt. So let's take a look at our performance on the real survey. And so we receive this data from the Blues, usually a little bit delayed. Our current data is through May of 31. But the survey includes about 30 questions in the CGCAP survey. We're focusing on on 11 questions that count towards our performance, and they're divided up into what we call composites. So there's a composite called Getting Needed Care, and it includes 2 questions. Getting appointments and care quickly, it has 2 questions now as of just in the last half of the year. There was 1 question that has been dropped from the survey process, and that's the one that we really don't like. It said, were you able to see your provider within 15 minutes of your scheduled appointment? And that was a tough one to make, but anyways, that's been removed. Coordination of care composite, there's 6 questions. And then how would you rate your healthcare quality? There's 1 question, it's answer 1 through 10. So in 23, we had really good performance. You can see our scores in the 80s and one in the 91. And then that translated to a 5-star. So we really had some of the best, we did some of the top patient experience performance across the state and across Agilon markets. What we're facing right now are these cut points or targets that are used to determine the star value are going up. And they're going up in 25 significantly. That's the predicted star. And so we're expecting that 85 for getting needed care is going to be 89 and 25. It's something, excuse me. And something similar for the other 4 composites, going up 4%, 2%, 3%. And so we really needed to jump in and say, how are we going to improve our performance? Even though we really have good patient experience for our patients, we need to improve that. And so our scores as of which I mentioned as a 531, we're actually already improving. So you can see we're already at an 89 level at this time of the year. Now it could go down, it could go up. So we're above where we were in 23, and we're actually meeting that target for a potential 5-star in 25. A little bit lower on the getting appointments. We're 1 point below. We're hitting on coordination of care, and a little bit low, 1.5 on the rating of healthcare quality. So this is what we've been working on. This is our improvement plan for 2025, even though we've started working on it. It takes time to make measurable changes in our performance around quality, or excuse me, around patient experience. This doesn't happen over a couple months. It's something that we have to work diligently on day after day for quite a long time in order to see our numbers improve on our performance for patient experience. So we try to simplify this work. How can we, rather than focusing on all the measures that are on it, the survey, or even the 11, is to really focus on a few. So we simplified it by identifying which composite questions we have lowest performance on across Answer Health. And then we're moving forward and we're providing improvement education and resources. So we're been including this information in our monthly PCP work groups all year long, and really focusing on in the last 5 months on best practices. We're having the value discussion today. And then another way we're emphasizing this work is the reports that you receive from NRC Monthly do have some tips in them. And they go from various questions. They're about 2 minutes. Some are half a minute, some are up to 4 minutes. So they're really quick ways to think about how you can improve your patient's experience. And there's some great ideas and best practices in each of those tips. So I would encourage you, as you're looking at those reports each month, that you click on that and listen to some of those tips. And then what Dr. Zalasko mentioned, we are starting a We're Listening campaign, and we're providing postcards to patients, and I'll go over that with you in just a minute. Okay, next slide. So let's drill down, like we talked about. We're going to drill down, we're simplifying. Let's work on our 4 lowest performing questions out of those 11 questions and see what our performance is and how we're moving towards improving those. So our lowest one, which is a little surprising because I know you all ask about prescription medications, specifically when the patients are being roomed, or as a provider when you're in the exam room with them. But this is the question: provider discuss prescription medications. The actual question says something like, did someone in this office talk to you about your prescription medicines? So there's some key words in there that we're talking about. We're talking about your medicine, your medications. We're talking about prescription, and we're also trying to pilot that medication. This is just how we see it in the reporting information, but the survey itself actually says medicines. So evaluating, does that make a difference to our Medicare patients on whether we talk about their medicines or medications? So we're asking some practices, try and trial that and see if that makes a difference if we talk about their medicines. In 23, we ended up at 82%, and that's pretty much where we've been running this year. We've seen no improvement. In fact, we went down a little bit, a slight decrease. So we're hitting that one hard and really trying to be prescriptive in how we're discussing these with our patients. The next is ease of getting specialist appointments. And so at 79% in 23, we've actually increased it already to 86%. We still need to go up, but we've had some improvement. And some of that is setting the expectation for the patient. When you're making that referral or recommending they see a specialist, is letting that patient know when they're going to be contacted about that appointment, who's going to be contacting them, and be realistic about when that appointment may occur. So if it's an urgent one, it may be within a few days, but if it's a routine, it could be out a couple of weeks, or even some of our specialists like endo and derm are out even longer than that. So setting that expectation, so patients, when they get this question, how easy was it to get your specialist appointment? They remember, oh yeah, I went in to see the specialist, but it took a while, but the expectation was realistic. The third one is provider office followed up with test results. Excuse me. We know that you all have processes around that as part of our PCMH, one of the capabilities, and we're at 87%, and we have improved to 89%. So we've made some gain on that just in the last few months that we've been talking about this. And so making sure your practice has a good process for reviewing test results as they're coming in, who's going to contact the patient and what time frame. Maybe it's different for normal test, abnormal test, critical test results might be different. But again, we can set that patient's expectations by when we're ordering tests, whether it be lab or radiology, of realistically, how long will it take for those results to come back? And maybe a while before you even get that test scheduled. It might be a few weeks out for some radiology. I do know that has been an issue this year. It's improving. But setting that expectation of the patient about when the results will come back and when and how, who will be contacted with the results, and what's the mode of that? How will they be contacted? Will it be a phone call? Will it be an answer, something in the portal? Will it be when they come in for the office visit, if they're coming in for their annual. So very clear on setting those expectations. And the last one where we had the lowest performance is got care when needed right away. So it's actually a pretty good score. We went up about 0.6%, but we still have opportunities to improve that more. And patients think about when they're calling your offices and saying they have an idea of when they want to get in, especially if it's between their routine appointments. Those routines where you're seeing patients every 6 months or quarterly, or maybe seeing them more often than that. If they have that appointment when they leave their office, then that's not quite as much of an issue as when those times where they see a patient are extended out. And so, what happens when they need to be seen in between those appointment times? And so how do they get to the appointment? So it's really important to have urgent, same day calls after hours, and so patients can get in to see you for needed care. Next slide. So we're going to move on to this We're Listening campaign. And this is what the postcard looks like. It's a 6x8 postcard. We've actually started delivering these to practices, and you should all have them within the end of the week or next week. And the reason we started We're Listening is the feedback we get from our patients it's very important to know how we're doing. And so we need we need their responses. And so the more responses we get, the more we can help identify where we have opportunities for improvement. The other thing is we noticed that with the alerts that I talked about with NRC survey, that last open question, we're getting more responses with, I really don't like these surveys. Please don't send me the surveys. I don't want to take time to do this. And so, in talking with Valerie, who you're going to just hear in a few minutes, we talked about doing this We're Listening campaign. Other markets across Agilon have done that and have seen positive responses by letting the patient know how important your feedback is to us. So the card is simple. Thank you for choosing us as your healthcare provider. Your feedback is really important to us and it helps us improve. You may be selected to participate in a survey. So letting them know they may get this call, they may get a survey in the mail. And letting them know that they don't have to respond if they don't like the surveys. This is voluntary. It's also confidential and how much it matters to us. So that's the front of the card. On the back, it's a little more wordy, but we're trying to somewhat teach to the test and also helping patients to understand how we're trying to improve their patient experience and help your staff know. And so we made it make the most of your visit. And we're going to offer this card to them when they're coming in. Mainly our Blue Cross and BCN Medicare patients will receive this card. And just some suggestions. Ask questions about how and when to get test results and needed follow-up. Talk about all your medicines, including prescriptions, over the counter. Can I lower the cost of them if there's concerns about that? And then we are experiencing some increased utilization in ED use and inpatient admission. So there's this part on review how to get care when you need it. Always make your next appointment before leaving the office. Call our office for same day urgent. Call us before going to the ER for non-emergent care. Use other resources for communication like the patient portal. Okay, next slide. And this is just a lot of information. It's important information. This is included in the packet with your card. So review it when you get it. I also send it on to every office manager saying we're implementing this. Read through it, talk to your staff about it. And especially there's that in preparation section. So there's some areas you might want to just take a look at in case the patient does ask or talk or want to review some of these that you're prepared for that. And I gave some tips right there, like process for when and how to get test results, prescription refills, specialist referrals, script your staff who are rooming patients and performing med reviews. Let's review and talk about all your prescription medicines, if that might be helpful for them, and discuss how to get the care or the right care at the right time in the right place. So thanks for listening, and please reach out if you have any questions, and I'll turn this over to Valerie next to carry on this discussion.
Thanks so much, Joan. Can everybody hear me okay?
Yes, we can.
Awesome. Thank you. So I'm Valerie Choniak, Director of Patient Experience at Agilon. I've had the pleasure of working with all of you now for almost 2 years. Time certainly flies. So let's talk a little bit about why we measure patient experience of care and CAPS. And what a lot of people don't know is CAPS stands for Consumer Assessment of Healthcare Providers and Systems. So let's just ground in that for a moment. Consumer assessment. We have to be cognizant that this assessment is based on that quality of service experience, not the quality of medical care. So when patients are judging or evaluating you, it is through the lens of a consumer, through the lens of somebody who has choice, through the lens of somebody who is non-clinical, through the lens of somebody that is looking for things like explaining things well, listening carefully, showing respect, spending time. Of course, we all know that the main goals of CAPS, of course, from the government, whether it's working with health plan payers or directly contracting with medical groups, is to create incentives, comparable benchmarks, and to transparently share those benchmarks, right? We want that competition throughout the nation. Those results are then publicly reported online through CMS and with health plan star ratings. And I know this slide's a little bit busy, but again, keep it for your reference and know that at the end of the day, beyond all of these things that the government and health plan does, you all know this is why you got into the business of healthcare, right? Because you want to take care of patients, because it's the right thing to do at the end of the day. You know, being in years of practice, when a patient loves you and they feel comfortable with you, they will be more open, they will be more compliant to adherence of care plans and their care instructions. They even do a much better job of managing their own conditions because now they're engaged and they trust you in the process. We also know that it provides positive clinical outcomes. It's going to have less hospital and ER readmissions. It ties very closely correlates to patient safety and, of course, patient advocacy and loyalty of you as an individual as well as the group as a whole. And last but not least, better business outcomes, right? If a patient likes you, they're less likely to sue you. All right. So just keeping it real. It also helps with less employee turnover because if we're all happy in our environment, if we're having a good experience, that's absolutely going to translate to our patients and our customers. And I will tell you, in the beginning of my career, I used to tout patients come first, but now it's really, we know physicians and employees come first because we need to heal our healers and they need to feel good in their environment with a human experience. So that way we can provide that to our customers. On the next slide, please. When you think about that quality of medical care, I want you to think about the treatment, the diagnosis, reading that test, prescribing that specific prescription. When you think about that quality of service, I want you to think about listening carefully, showing respect, spending time, explaining things in a way the patient can understand, exactly like Joan just said, right? When you're explaining how to take that medication, when you're explaining those tests and those test results, who they're going to get them from, what the best source is to get them, why it means what it means, specialist referrals, and setting that expectation for when that appointment might occur, when somebody might reach out to you. This is why someone like myself, who's non-clinical, I could not possibly evaluate any of you on that quality of medical care that you provide. I don't have that education. I don't have that expertise, but I do know how to judge you on if you're introducing yourself properly, if you're mispronouncing my name, if you're rushing me through the visit. And these are the things that I can evaluate you on because I know intrinsically what it feels like to be respected or disrespected, to feel valued, to feel if I'm being treated with empathy. And this is exactly what CAPS is. And again, as Joan mentioned, right, for consumer assessment, this is through the lens of not just a patient, but a consumer who has that power to choose. So I read a really compelling article. It's a little older. It's from the Journal of Medical Practice Management from April of 2016. It's a great study if you'd like to look it up. It was a study conducted by Vanguard Communications, and they're a healthcare marketing company. And they reviewed thousands upon thousands of online complaints. And the title of the study is Blame Customer Service, Not Doctor Care. And after analyzing those thousands of online reviews from Google for medical practices and various clinics, their summary of findings, it was very profound. 96% of patient complaints are customer service related. 4% are related to that quality of medical care or misdiagnosis. And this goes back to what I said earlier. The majority of patients that you're taking care of, those seniors, they're not doctors. They are not clinical. So they do not know how to judge you if it's a misdiagnosis or not unless they get a second opinion. So overall, 96% of those complaints are service related. And we see that in our NRC survey as well that we conduct, that mock survey that Joan mentioned, where we see thousands of comments. So it follows in suit to even this study from 2016. And you'll see that 53% of those complaints are related to communication. 35% of those complaints are related to long wait times. And that is across the nation. You will see that. It is the consumer-driven healthcare world. We want everything yesterday. And 12% of complaints are related to staff and making sure that the environment feels good when they arrive. So being cognizant that if you are taking care of somebody who is, of course, clinical and non-clinical, that could be a little daunting, right? Because they're going to be judging or evaluating you on everything. But when you step into the exam room, I want you to think about it from a lens of not just that quality of medical care, but being cognizant of the quality of customer service that you're delivering. Because I say this half jokingly, you could be the best medical doctor in the world. If you're a jerk, no one's going to come see you. So we have to make sure that we're connecting with our patients, and we have to make sure that at the end of the day, we're bringing this back to a humane experience. On the next slide, you'll see that if according to research, right, if customer service is truly that differentiator, we have to strive to exemplify customer service in every encounter. And I'm a firm believer that service excellence is the key to an exceptional patient experience. And I'm sure you've heard this term before, customer service excellence. It's shortened to service excellence. And as Joan mentioned, it's the ability to consistently meet and manage expectations. So I always approach patient experience from a psychological perspective. I'm not asking you to completely revamp your operations. I'm just asking you to think about redefining how you currently approach the day. So to understand how we, even from a psychological perspective, create expectations, please know that we base our own personal expectations on our current environment and past experiences in that environment, or one similar to it, one like it. So if you've been in an educational webinar before, you're likely right now off camera and you might be multitasking, you might be checking out a little bit, you might be doing some other work on the side, playing catch up, maybe just scrolling on your phone, answering emails. Or hopefully through this value presentation, we're changing that expectation and you're engaged and you're listening carefully. Another example might be if I've been seeing Dr. Smith for 25 years and Dr. Smith typically runs an hour behind, it is what it is. I love Dr. Smith. That's why I've been seeing her for 25 years. But if I'm a new patient of Dr. Smith's and she's running an hour behind, hello, you guys have any idea what you're doing in this office? Why is this taking so long? You guys are getting so big and so impersonal. A friend of mine recommended that I come here, but geez, an hour behind and nobody's keeping me informed or updated. This is terrible. So you can see people that have similar experiences can have very different expectations. And when we're talking about the CAP survey, it is always asking how often are we doing things? It's not asking, did you or did you not diagnose somebody properly? They're asking, how often are we consistent in our behaviors to take care of your needs? Because we all know consistency equals predictability. Predictability equals comfortability. And when somebody feels comfortable in their environment is when they're going to be able to engage in a much better way. On the next slide is just a little fun game. I'm going to wake up your brain cells and get your neurons firing. Let us know in the chat or shout it out loud. What colors do you see here in the dress? Is it blue and black? Is it white and gold? Is it something else? Would love to hear from all of you. Dr. Lewin says blue and brown. Okay. What else do we have? I got blue and black. Whoop, keep it coming. White and gold, blue and black, white and gold. This is great. Look at, isn't that amazing, right? Is it because we haven't gotten to our second cup of coffee yet? I'm not sure why we all see different colors. I'm showing you the same picture in this presentation. This is fabulous. Thank you so much for your participation and engagement. Blue and brown. So let's pick on Dr. Lewin for blue and brown. And let's pick on, I don't know if it's Dr. Sherry Hartman. So if you two see blue and brown when everybody else sees blue and black and white and gold, does that make you two the difficult patients in the room because you see things differently than everybody else? It's interesting, right? And this goes for things that we hear as well. Our perception is our reality. It is based on our current stimuli. It is based on our mental state in that current moment. It is based on past experiences, past emotions. A patient might run into somebody at the front desk that reminds them of someone they don't like, and all of a sudden it's a bad experience, right? So this is all about psychology when we're looking at patient experience. Again, not asking you to overhaul your operations, but just think about it a little bit differently and how patients might might see things and hear things differently. I like it, Dr. Lewin, just the most astute ones. Fair enough. I'll go with that. So just again, liking to play these fun games, getting those neurons firing, getting you to think about things in a different perspective, and knowing that patient experience is truly the differentiator, and knowing that when we can provide that compassionate care in a quality setting, everything else will fall into place. So thank you all so much for the time. Thank you for playing this lovely little game with me. Thank you for taking time out of your very busy schedules and day to talk about patient experience. Very, very grateful. And I will hand it on to Matt to talk about statin therapy for Medicare quality measures.
Thanks, Valerie. Thanks, Joan. Good morning, everyone. Thanks for joining the webinar this morning. For those that don't know me, my name is Matt. I'm the clinical pharmacist lead here at Answer Health. The Answer Health pharmacy team has been working with your practices now on various Medicare quality measures, including the two that I'll be talking about today related to statin medications. As we go into the fourth quarter, we want to continue to improve performance in these measures. My hopes with this webinar is that it will serve as a review of these measures and provide some tips and tricks we can utilize at your practices to continue to drive performance. And also, too, just to note, you may have noticed in the previous two medical director updates from Dr. Zelasco from September 13th to September 20, there was a link to a best practice guide highlighting the two statin therapy quality measures we'll be talking about today. And this presentation will focus on information provided in that best practice guide. So if you haven't seen it yet, I encourage you to look at it, print it off, utilize it as a resource if any questions come up regarding these measures at your practice. So just an agenda of what I'll be going through today. We'll be touching on what are the quality measures related to statin medications. We'll go over what providers can do to improve performance in these measures. We'll review some best practices. And then I did include a couple of patient cases of what I've been seeing as I've been looking at charts and everything at the various practices I've been going to. Next slide, Matt. So what are the two quality measures related to statin medications? One is statin use in persons with diabetes, abbreviated SUPD, and the other is statin therapy for patients with cardiovascular disease, abbreviated SPC. I think just for ease during the presentation for the SUPD or the diabetes measure, I'll just refer to that as the diabetes statin measure. And for the SPC or the cardiovascular disease measure, I'll just refer to that as the cardiovascular disease statin measure. So how are each one defined? The diabetes statin measure is the percentage of patients with diabetes receiving statin therapy. The cardiovascular disease statin measure is going to be the percentage of patients with clinical ASCVD receiving statin therapy. And basically, the ASCVD is going to be any patient with a history of a myocardial infarction, a coronary artery bypass graft, ischemic vascular disease, PCI, and other revascularization procedures. And how is each measure calculated? So for the diabetes statin measure, the measure population or the patients that are going to be included in the measure are going to be patients aged 40 to 75 years of age who were dispensed at least 2 diabetes medications during the measurement year. And for the cardiovascular disease statin measure, those patients in that measure are going to be males 21 to 75 years of age and females 40 to 75 and identified as having clinical ASCVD. Compliance is considered for the diabetes measure if a patient fills a statin medication of any intensity during the measurement year. And for the cardiovascular disease measure, it's going to be patients who filled a statin medication of moderate intensity or high intensity during the measurement year. And also too, just if the patient is basically in the denominator of the measure and not on a statin medication, a lot of times we refer to this as the patient has a gap in care. And so by prescribing statin medications and getting these patients on statin medications, we usually call that closing the gap. So in case you hear that verbiage thrown around. Next slide, Matt. So what can providers do to improve performance? Well, the most obvious answer is going to be prescribe one of the following statin medications to your eligible patients. Again, highlighting that for the diabetes statin measure, any intensity statin will work to close the gap or make the patient compliant with the measure. For the cardiovascular disease statin measure, only moderate or high intensity statins will work to close the gap. And now I understand too, there are a number of reasons why a patient might no longer be on a statin medication, or maybe a statin medication isn't appropriate for the patient. For these patients, Matt, if you want to go to the next slide. If the member has one of the following reasons in the chart below for not being on a statin medication, you can submit the corresponding ICD-10 code. A lot of times we'll refer to this as exclusion codes through the medical billing. And just be aware that the codes for diabetes, for the diabetes statin measure, are going to be on the left, the SUPD, and the codes for the cardiovascular disease statin measure, SPC, are going to be on the right. In general, these codes are going to include any patient with cirrhosis or end-stage renal disease, pregnancy, muscle-related adverse effects, so myopathy, myositis, and also too for the diabetes measure, pre-diabetes and PCOS are also a couple of exclusion codes that are available. And this list also is included in that best practice guide that was included in Dr. Zalasko's medical director update. So in case if you do have a patient with one of the listed reasons for not being on a statin, if you're not sure what code to use, you can always refer back to that best practice guide, and that can kind of help clear up any kind of confusion. Next slide, Matt. And just a little bit of additional information about statin exclusions. Exclusions codes must be billed annually. The condition that the code referred to does not necessarily need to occur in the same year that the code was billed. The patient's medical chart should just reflect a history of. So for instance, if you have a patient who was on a statin 3 years ago and stopped it, you'd want to document myopathy for it. And then each year going forward, you would want to make sure that you continue to bill that myopathy code, and that will get the patient removed from the measure. There is some nuance with the code, so you want to pay attention again to the codes on the previous slide. Only the codes listed on that slide will work. So what I have encountered at practices, for instance, if you have a patient, say with pre-diabetes, maybe an A1C of 6.1, but you want to start them on metformin, well, starting them on metformin is going to put them in the measure, but pre-diabetes might not necessarily be a reason to start them on a statin medication. So you'll want to make sure that you code for the pre-diabetes code. Sometimes I've seen people use impaired fasting glucose, and if you look at the previous slide, that's not one of the exclusion codes listed. So if you use impaired fasting glucose, that won't get the patient excluded from the measure, whereas if you use pre-diabetes, that will get them excluded from the measure. And same with muscle symptoms, myopathy, myositis, that will work for the SUPD or the statin, the diabetes statin measure and the cardiovascular disease statin measure. Whereas if you code for myalgia, that will only get the patient out of the cardiovascular disease measure. So again, if you have a patient with diabetes who's in the diabetes measure, you're going to want to make sure that if they have muscle symptoms, and that's the reason why they're not on a statin medication, you're going to want to make sure that you code it as myopathy or myositis, and that way they'll appropriately be removed from the measure. And also to members that are in hospice at any time during the year or received hospice services for the cardiovascular statin measure too. If a patient is in palliative care or is age 66 and older with advanced illness or frailty, that can also get them removed from the measure. Do you want to go to the next slide, Matt? So just to highlight some quality measure best practices, there are 2 ways to close a statin therapy related gap. One way is for the patient to fill the statin medication through the Part D plan. The other way is for the provider to bill an exclusion code. For providers, I encourage you to prescribe a statin medication yearly to patients diagnosed with diabetes or ASCVD. If you have a patient and you're the one who has been prescribing their statin medication, but if you look in their medication list and the last time that you prescribed that statin medication or sent in a new prescription was 2021 or 2022, there's a high likelihood that the patient's no longer taking that medication. And so it would be a good conversation to have with the patient to make sure that they continue to take that medication. So one way to make sure that they continue to take it would be making sure that you're renewing these prescriptions every year for these patients. And also too, for patients with diabetes, make sure that you offer a statin medication or offer a statin medication for patients for primary prevention for any patients with diabetes age 40 to 75, and this is regardless of their LDL levels. This recommendation is actually supported by the American College of Cardiology, the American Heart Association, and the American Diabetes Association. So really focus, regardless of LDL levels for these patients, if they're 40 to 75 and they have diabetes, technically a statin medication would be indicated. And I can understand that some of these patients might be hesitant to start a statin medication. If they are, you can always consider starting with a low dose or even intermittent dosing twice weekly, every other day. This isn't ideal, and I don't want you doing it for every patient, but if you have a patient who is very hesitant to start a statin medication, maybe otherwise won't start a statin medication, encouraging them just to try it twice weekly, it might provide some LDL lowering benefit, maybe some cardiovascular risk reduction, but at least it might help with getting some buy-in from the patient. I think the general thought would just be that some statin is better than no statin for these patients. And then going into a couple of patient cases, Matt, if you want to go to the next slide. Your patient Anna comes into the clinic today for a diabetes check. She's a 68-year-old female diagnosed with type 2 diabetes in 2019, currently on metformin, which, as a reminder for the diabetes measure, if she fills that metformin twice, that's what puts her in the diabetes statin measure, as well as a handful of other medications. Next slide, Matt. Her blood pressure was 138/88, and she had some lab work done ahead of the appointment today, showing an A1C of 6.9, total cholesterol of 184, triglycerides 257, HDL 34, and LDL 86. So I know we're thinking, great, LDL is under 100. We're thinking she's great and we're going on our way. But really, is a statin medication going to be indicated for Anna? Well, thinking about the criteria, she has diabetes, which she does, and she's aged 40 to 75. Technically, yes, if you want to go to the next slide, Matt. A statin medication is indicated for her. Some talking points to consider having with her would be that, again, the statin medication is recommended for anyone aged 40 to 75 with diabetes, regardless of LDL. And really, to drive home the point would be, don't focus on cholesterol lowering or LDL lowering so much. Really, the goal with the statin medications for these patients is going to reduce their risk of a heart attack or stroke. And that's really what we're after. So I think having some of those kind of conversations versus just focusing on LDL lowering or thinking, my patient's LDL is under 100, she's okay, we don't need to worry about it. Well, if you wanted to calculate it further, you can use this 10-year ASCVD risk calculator. This is available online. A number of websites have it posted. I like the one from the ACC. They have a fantastic one. They also have an app available that you can download on your phone. It's called ASCVD Risk Estimator Plus, and it's a fantastic app. What you can do is you can input the patient's age, gender, race, total cholesterol, HDL, systolic BP, treatment for hypertension, history of diabetes, and history of smoking. And this will actually calculate their risk of their 10-year risk of having an ASCVD or cardiovascular event in the next 10 years. And I'm remembering what Anna's LDL was, it was 86. So we would think that she's doing okay, but when we calculate her 10-year ASCVD risk, we can actually see that she has a risk of 25.9%, which actually puts her at high risk for a statin medication. So this could be another talking point that you could have with her, that really starting a statin medication is going to help lower this 10-year ASCVD risk. And one of the nice things too about these calculators is a lot of them have a button that you can click that actually shows the impact of therapy. So if you were to start a statin medication on the patient, it actually can reflect what kind of risk reduction the patient might be getting. I think for Anna, when I tried it, it lowered her risk by about a little under 7%. So again, it might help drive home some talking points to the patients, maybe help get some buy-in as you try and encourage them to start a statin medication. And then if you want to go to the next slide, Matt. And for our second patient case, we have a patient, John, who comes into the clinic. He is a 73-year-old male with a history of myocardial infarction in 2018, and he's followed by cardiology. When rooming John, your MA went through his medications, and John noted that he had stopped rosuvastatin, and his cardiologist put him on Zetia in its place. Now, John has a history of ASCVD based on his myocardial infarction, so he's going to be included in that cardiovascular disease statin measure. So what impact is him discontinuing that rosuvastatin going to have on that measure? Well, for the measure, for the cardiovascular disease statin measure, only medications that are statin medications are going to close the gap. So things like Zetia, fenofibrate, PCSK9 inhibitors like Repatha, none of those are going to work to actually close the gap. So if the patient, John, isn't on his statin medication, he's going to be having a gap in care. So what do we do? Matt, if you want to go to the next slide. We can ask John why he stopped his rosuvastatin and make sure we document why. In this case, let's say John tells you that he stopped his rosuvastatin because he was experiencing severe muscle pains that ended up resolving upon discontinuation. He was adamant with his cardiologist that he did not want to take a different statin medication. So in his best interest, the cardiologist tried putting him on Zetia instead. And as a result of this, we would want to make sure that we submit one of the two diagnosis codes for myopathy or myalgia, since this patient is in the cardiovascular disease measure. Again, just driving home the point that that G72.0 code, drug-induced myopathy, will work for diabetes statin measure and the cardiovascular disease statin measure. The M79.10 myalgia, that's only going to work if the patient's in the cardiovascular disease statin measure. Since John is in the cardiovascular disease measure, either one will work for him. And we'll want to make sure that we continue to build this code annually. And again, this will make sure that he's appropriately removed from the measure going forward. And ultimately, like I said, when in doubt, if you have any confusion about what codes to use or anything like that, by all means, feel free to reach out to your Answer Health pharmacist or your clinical improvement specialist. We'd be more than happy to make sure that the right ones are being used to make sure that your patients are appropriately removed from these denominators if they're not going to be on a statin medication due to any of the listed reasons. And with that, Matt, I think if you want to go to the next slide, I think that will be it.
You do have a couple of questions in the chat, Matt.
Okay, perfect. I can try and find them. Okay, so Dr. Lewin asked, how are patients with having clinical ASCVD identified? Do they have a stent, bypass, or does having an elevated calcium score count? So the way that the ASCVD patients are going to be identified, it's all based on diagnosis codes. So any kind of diagnosis of ASCVD is going to put them in. And this list is very, very long. So essentially any patient, if they had a history of any kind of atherosclerotic disease, that will put them in the measure. Does having an elevated calcium score count? If it's just strictly lab work, no. But if you attached any kind of diagnosis of ASCVD with that lab work, then they will be included in the measure. So ASCVD is identified by diagnosis. So I would say having an elevated calcium score may or may not put them in the measure, depending on what kind of diagnosis is attached to that. And again, we do have a list available of this if you have any questions or wanted us to double check if a certain diagnosis like that would put the patient in the measure. You can send it my way or check with one of the other Answer Health pharmacists. We'd be more than happy to look into that. Dr. Parker mentions, did you say a history of myositis or myopathy will work for exclusion? So you'd want to, the code to use would be a code of drug-induced myositis or drug-induced myopathy. And then typically in the diagnosis, you can usually attach a note, and I would just document that the patient had a history of myositis or myopathy. So for a patient with that, you would want to submit, say, G72.0, drug-induced myopathy. And then usually a lot of times you can make a note with that and document just that the patient had a history of, say, severe muscle aches or pains due to a statin medication. Framingham versus ASCVD calculator, which has the best data. The one that the ADA guideline from Dr. Lewin asks if the Framingham versus ASCVD risk calculator, which one has the best data. The one that I'm familiar with is the ASCVD 10-year risk calculator by the ACC, and that's also the one that the American Diabetes Association and their ADA guidelines, I believe, recommended as well. So that's one that I usually prefer. I think ultimately, for the most part, I would say the 10-year ASCVD calculator is the one that most guidelines are recommending. But I can always double check for you, Dr. Lewin, and get you a definite answer. But I would say the ASCVD risk calculator is the one that's my go-to for now. And Dr. Lewin asked, the ASCVD calculator tends to overestimate risk. And I agree with this. And there is actually a new calculator coming out too. I think it's called the Prevent calculator. And this one does help.
I drank the other person.
I agree, it does tend to overestimate risk. There is a new one coming out too that I've encountered. It's like the 10-year prevention or prevent calculator. I think just for the sake of the measure in the diabetes, for our diabetes patients, really the diagnosis of diabetes is really going to increase their risk. So I'm thinking regardless of what calculator that you use, just because the patient has diabetes, they're going to have a relatively high risk, and that statin is going to be indicated, or that calculator is going to increase the relatively high cardiovascular disease risk. But I agree with you, Dr. Lewin. I think for a patient, especially without a patient with diabetes, it can potentially overestimate risk. And again, for me, if a patient has diabetes and they're aged 40 to 75, my goal would be just to, again, have a conversation about, risk and LDL versus LDL lowering. But yeah, in general, I would say a diagnosis of diabetes, if your patient has diabetes, their risk will be elevated enough regardless of what calculator that you use, where a statin would be indicated for them. Thanks for the questions. Anyone else?